Healthcare is too expensive. Employers are offsetting costs onto their employees. Who will make health benefits affordable for hardworking Americans and their families? You will. This is the Empowering Plans Podcast, a show dedicated to helping you once again emphasize the benefit in benefit plan. Now prepare to learn, plan, save, and protect with the FIA Group.
Well. Hello. Welcome to another episode of the FIA Group's Empowering Plans Podcast. You know, when I think about the name of this podcast, Empowering Plans Podcast, there's a lot of P's, and I don't know who came up with this or who's to blame, but I'm going to put my finger and I'm going to point it at our producer, Pat, the podcast producer Santos. Pat, I'm very excited to be hosting today's FIA Group Empowering Plan Podcast. And let me tell you why. Because with me is Kaitlyn MacLeod, okay? And before I introduce Kaitlyn, I know I've mentioned this in the past and we had this discussion once before, but for all of the listeners, you know, I need them to know this. Back in the day, so late 80s, early 90s, I was a huge fan of the Highlander franchise. And, you know, a lot of people, they think of the movies and Christopher Lambert and his role as Connor MacLeod in those films. But I was actually a big fan of the television series. And for people who are scratching their heads saying, what is he talking about? I found out that TV series went for 6 seasons, I think. 6 seasons! That's almost a decade. Incredible, right? And it was all about Duncan, man. That character, he was the man. And so, Kaitlyn, I know I've asked you in the past whether you have any sort of relationship with the Clan MacLeod and the Highlanders, and whether you might be immortal. But for the sake of the audience, can you introduce yourself? Let people know who you are, what you do at the company, but most importantly, whether you're an immortal. Kaitlyn?
Of course, Ron. Thanks for that great introduction. My name is Kaitlyn MacLeod. I am a health benefit consulting attorney here at the FIA Group. I joined 1 year ago this month, and I primarily work on consulting questions that come in from our clients, as well as the NQTL comparative analysis for mental health parity. And as for being immortal, I don't think I can really say, but I guess we'll find out.
You know, I'm wondering if we continue to have you participate in these podcasts, maybe you're going to, you know, like breadcrumbs, you know, you're going to leave little hints and clues, and people who listen in on every episode, you know, and pay attention, they could move the pieces around like a jigsaw puzzle and figure out, you know, all the references to, you know, things that happened in the 1800s and, you know, somebody that you met that happened to pass away in the late 1700s. Oh, this is mysterious. But you know what's, I think, even more intriguing than your tale as the Highlander, Kaitlyn, and that is mental health. Mental health. And you know, and everyone's like, wow, that was a terrible transition, Ron. Listen, okay, I do my best, all right? I'm trying here. You know, Kaitlyn, today we're going to talk a little bit about mental health in general, but more specifically, how it impacts our clients, benefit plans, brokers, third-party administrators, stop-loss carriers, pretty much anyone and everyone in the health benefits industry, including providers. You know, sometimes I feel like we leave them out, but I used to say that healthcare is comprised of the 3 Ps. No, I'm not talking about the Empowering Plans podcast, and I'm not talking about the Empowering Plans producer, Pat. No, I'm talking about providers, patients, and plans, right, or payers. And those are the 3 Ps. And often, you know, we're hyper-focused on the payer and the patient, and we forget about the provider. But, you know, what's going on in healthcare today, and mental health in particular, is impacting all of the 3 Ps and beyond. And just to kind of set the stage, you know, mental health and brain health have been topics of conversation and a focus for health benefit plans for a number of years, certainly well before the COVID-19 pandemic that we're currently in the midst of presently and have been for the better part of almost 3 years at this point. And the pandemic didn't cause people to suffer necessarily conditions of mental or brain health, but it has certainly increased the demand. And I think while certainly there are some people who things have been triggered or they're suffering as a result of the pandemic, for many more people, a mental health or brain health condition already existed. And this really exacerbated it or made them more aware of its presence. But regardless of whether it's a cause or a catalyst, we've certainly seen over the last few years a spike in demand for mental health and brain health care, whether it's counseling or pharmaceutical treatment, psychologists, psychiatrists, therapy. Also, a lot of people looking to be inpatient at a facility or a clinic or rehab facility, all sort of originating from this. And when we talk about mental health and brain health, we're not just talking about conditions of the mind, whether we're talking about psychological, emotional conditions or disease. We're also talking about all of the things that kind of stem from it, whether you're talking about harming oneself, substance abuse, addiction. Those are all sort of trickling down or rippling out from the mental health pandemic that really has sort of come alongside the COVID pandemic. And, as a result of this, I think it's really highlighted the two big issues that, Kaitlyn, I'd like you to kind of talk about today. One relates to the shortfalls on the part of the health benefit plans that we represent and with whom we work. Issues of what's covered, what isn't. I know you want to talk a little bit about mental health parity, both its origin and more specifically NQTL. We'll talk about that a little bit later. But, before we do that, you're going to talk about some recent developments in this space. But one of the issues, of course, is, like I said, shortcomings on the part of these plans and coverage. The second issue that we really need to focus on has to do with the shortage of providers. Remember, I mentioned providers were important as well. Supply and demand. Anyone who took economics, and I still remember taking economics, microeconomics, and macroeconomics. I can't remember the difference between the two, but I did do both in undergrad. My father's going to kill me. He's got a PhD in economics, right? Microeconomics, I believe. But the point is, I do remember that when demand goes up and supply stays flat or is reduced, then the price of that supply increases, right? Rarity equals an increase in price. And for us who represent the payers, that's not so good, right? That's not great to hear, right? We don't want to hear that there's an increase in cost because of a lack of supply. And so it really behooves us to not only secure care and treatment for our plan members, but to also identify as many solutions as possible so that rather than fighting over the pie, we're making the pie bigger. So before we get into discussions of mental health parity and NQTL testing, which I know is top of mind for a lot of people on this topic, Kaitlyn, I know that you've looked into some recent developments in this space that you were excited to talk about. So let me turn it over to you to hear about some of the news in mental and brain health.
Yeah, absolutely. I think this week or last week, the big news is that the 988 crisis response line has officially been launched. And a lot of states are hoping that this will really strengthen their community-based crisis response for any mental health crises, not only related to suicide. And the Biden administration has really shown in the past 2 years, but especially this year, I think, their commitment towards providing additional mental health benefits for the American people. Biden has actually proposed in his 2023 budget over $275 million for the DOL to go over mental health parity audits and $125 million to states to support enforcement of mental health parity laws on the state level as well. As you said, a lot of the reasons are that cost for mental health care, is a primary reason that people don't go seek mental health care, whether it's under a plan or on their own. And that's one of the administration's goals, is trying to get additional access to providers in the locality where they live or through telehealth, whatever. They're trying to get the cost of mental health care somewhat in parity with what plans are paying their medical providers. And one of Biden's proposals and strategy is he is trying to propose that all health plans provide at least 3 behavioral health visits as preventive care per year without cost sharing. And I think that's a pretty big ask for a lot of plans. Some plans don't even provide any mental health coverage at all, and it would technically put most plans under the scope of the Mental Health Parity, Addiction, and Equity Act purview, so they'd have to provide all their health care in parity with their medical care. So, I think it can go either way. I think the administration is really trying to address the crisis by providing all these additional resources and are trying to get all this additional funding. But, it might result in some additional costs to plans as well and participants too.
It's really interesting you bring that up, Kaitlyn, because Mental health parity in general is not a new thing. The issue of NQTL and testing and the DOL audits that you're going to talk about a little bit later in greater detail is more of a recent occurrence. But the requirement that these benefit plans demonstrate mental health parity or feature mental health parity in general predates the testing and the audits that we're dealing with now by quite some time. And it's always been interesting because people, I don't think, really ever truly understood what it meant. So often we'd get questions from clients, does this mean that we need to provide mental health benefits? Which is interesting because you're talking about now that they're talking about mandating some benefits, but that should just go ahead and show you that it wasn't actually required previously. It really was more of a, if you provide it, then you need to provide it at the same level and with the same rules apply to mental health benefits as your medical health benefits. And so parity or balance. And so for some people who understood that, it was almost an incentive not to provide mental health benefits or brain health benefits because there was this feeling that, oh, well, if I give you an inch, you're going to demand a mile because I need to sort of meet the same standards that I set for my medical care. And so that was a bit unfortunate. And we spent a lot of time as an organization consulting with employers and plan sponsors and third-party administrators regarding mental health benefits and showing them that, look, if you look at the sort of the cost benefit analysis, it's worth it. There's value there. I mentioned before about how mental health and conditions of mental health could potentially affect a person in a more general sense, not only their physical health, but also, their performance. Because remember, we're talking about more often than not, employer-sponsored employee benefit plans, right? So these are benefits that an employer is providing to their employees. Well, presumably when you hire these people, it's to serve a purpose, right? The people you're hiring have a job to do. You hired them for a reason. You're paying them to do this job. When people are suffering from a physical condition, an injury to their body, we have so many benefits in these plans to get them treated and taken care of and well again, not only because we care about our people, because we want them back on their feet and back at the office, back at the facility, back at the factory, doing the job for which we're paying them, right? A productive employee population. The same issue comes up with mental health. When a person is suffering from something like anxiety or depression or things more severe, ultimately it affects their ability to come into work and to be a contributor, to be productive at the level you were expecting and for which you're compensating them. So there really is, in addition to altruistic reasons, selfish reasons as well to provide these health benefits, even when you're being required to do so in a way that's in parity with your medical health benefits. So I think finally people are really starting to get that. Certainly many, if not most, of the health plans that we review include mental health benefits. Of course, the problem then is they're offering the benefits, but are they in parity? And testing for parity, NQTL testing and audits that are going on have been a hot topic in our office for a couple of years now. But, with the recent attention being paid to really what is sort of a pandemic within a pandemic, and all the political movement taking place now that you just talked about, Kaitlyn, I think now more than ever, these plans need to be focused on being able to prove that they are indeed in compliance with these parity requirements. And so I wonder if you could talk a little bit about some of the recent developments on the parity front and more specifically the testing and QTL and the things that we're dealing with presently.
Of course. So as Ron mentioned, there's been a lot of developments in the NQTL space as part of Biden's proposals for Congress. He's also trying to get the DOL the ability to pursue civil monetary penalties for entities like TPAs, PBMs, UMs, and networks that don't comply with the mental health parity laws. This would hopefully, really start vendors to be more and more aware of what their practices are and how they are acting and whether it's in parity or not. When it comes to the NQTL process, every plan has to look not only at how their plan is written and how their policies are written, but how they are actually applied in practice and whether those two match. And if they do match, are they both in parity or are they both out of parity, or is there a mismatch? Because all three of those can have an effect on the ultimate parity of the plan. So I'd say one of the main hurdles for self-funded plans these days is actually having to produce the NQTL comparative analysis report. we've been getting a lot more interest in this service since we started it, and more people are realizing after the 2022 report to Congress that the DOL really cares about proving that plans are not acting in parity. So you should care too. And this is like a newer requirement, even though the mental health parity laws has been in effect since 2008. And some vendors are still, trying to get caught up, which is fine. But the DOL has really indicated that plans should already have these reports on file. And if your vendors aren't documenting their requests and aren't cooperating, you need to name names, provide quotes, show any emails that you are trying to comply with the law, even if your vendors are not at this moment. But one other part that the DOL is really interested in this year and has, had some announcements about is making sure that mental health providers are in network to ensure that people have, lower costs to go see providers. They're available in their area. But the main issue with that is the lack of providers that are in those networks. There's many reasons for that. There's obviously a shortage of mental health providers in the country, and in particular zip codes. But the other issue is that networks are reimbursing at different rates than they are for medical surgical rates, and that they're not trying to recruit more. And one interesting piece that has come up repeatedly is network reimbursement rates. And I'd say many clients have asked us, does that even matter? Like, the cost sharing is the same for all the participants, whether it's on the medical side or the mental health side. So what does it matter what the network actually reimburses providers at? Why it matters is that providers are not joining the networks in the first place because the mental health providers are typically being paid less than their associates on the medical side. And so that's one of EBSA's network adequacy groups really focus this year, is figuring out how those rates are determined and how to increase those rates to be in parity and to ensure that more networks will try to get more providers in their network that will accept higher rates. Because, in a lot of cases, the providers are accepting the rates. If they're accepting the rates and the rates just happen to be lower, like, is that an issue? It is, because other providers are choosing not to join the networks because they aren't being paid at the rates that their compatriots are. And one other, big part of mental health parity and EBSA's goals this year is analyzing network adequacy. And by that, we mean, a plan doesn't only need to be in parity based on their plan, but also in their network practices. So a network has to have equitable access to in-network providers and facilities for mental health, substance use disorder treatments, as well as medical surgical treatment. This does not mean, there has to be the same number of psychiatrists as there are to cardiologists in a zip code. Obviously, that's not the case. And a lot of times plans or the networks themselves can employ additional means to try to ensure access to these services in the surrounding area that were not previously pursued. And plans can also think about mental health telehealth or trying to get RAP networks or other things to try to ensure that they do have sufficient access to mental health providers in network so that there is, an equitable access on both sides.
You mentioned that you don't necessarily mean there need to be as many psychiatrists and psychologists or therapists as cardiologists. But I will say, if you look at just our employees as a population, I think if we had more mental health care providers, we might need fewer cardiologists. But, it is so interesting because it's almost as if we're working from behind in a lot of ways, both from the provider population and from the plan population, where I think that as employers and plan sponsors and members of the plan, so patients, providers, the idea that there is this need for medical healthcare services has been apparent since, one caveman beat another caveman over the head with a stick and he started bleeding, right? The idea that mental health is not something that you could just walk off or take a nap, and that, there are actual biological and physiological sort of underlying things that can cause it, as well as other triggers that are more environmental or, otherwise. It really does require a completely different skill set. And we just don't have the same number of people who are involved in learning about providing that kind of care. The plans that sponsor it or the insurance policies that cover it, again, are sort of working from, I guess they're a little bit behind because they haven't always provided these benefits, and it's a more recent occurrence, this idea of parity. Like you said, we're at the better part of almost 2 decades And yet it's still something that now they have to do these audits in order to ensure it's actually happening. I guess my question of you is, you work with a lot of benefit plans. You are aware of what's going on from a legal perspective and what's in the news. So you see these plans being drafted, you see what's happening with the law. My question for you is, where do you see things going? Do you think that it's going to continue to be sort of the DOL pulling teeth and sort of baby steps? Or do you think there's going to come a point where there's just this massive revision of plans, the benefits increase, the provider population increases? I mean, again, it's sort of a best case scenario, but I guess I'm asking what your prediction is for our industry as it relates to mental health care in particular.
Yeah, I mean, from my experience, a lot of plans are really receptive to feedback on whether their plan is in parity or not and how to fix it. And they do fix it. So I think, once people become aware of the issues, I think in most cases that they will address them. When it comes on a wider scale on the nationwide basis, I think we'll only see like nationwide change once there is some additional backing for the DOL's threats. Once they are able to actually employ penalties against the vendors, I think then vendors will really try to ensure that the plans that they're backing and that they're administrating are actually in parity so they don't get in trouble too. So I think, there's both ways, but I think it'll be a longer process, at least until those penalties do or do not get passed by Congress.
Wow. All right. Well, I guess this is something that we're going to have to keep our eye on, just as an employer ourselves with our own health plan and a group of employees that, again, we want to help them stay as well as possible and at the same time be as productive as possible, administering our own health plan, as well as servicing other employers' benefit plans and the administrators that service them to ensure that they're in compliance and that their plans accomplish what they're trying to accomplish. And also just bringing just sort of general knowledge and education like we did today. This is a topic that we're going to keep our eye on and continue to report on a regular basis. But in the meantime, I want to thank you so much, Kaitlyn, for joining me today to discuss this very important topic.
Thank you for having me.
So on behalf of myself, Kaitlyn, the entire FIA group, and most important, Pat, the man Santos, the podcast producer extraordinaire, thank you for joining us yet again for another FIA Group Empowering Plans podcast. Be well, take care of yourself and each other. We'll talk to you soon.